is a neoplasm of lymphoma is a neoplasm of lymphoid cells. It is a monoclonal proliferation. Some are aggressive, others are indolent, but may transform. If you go back in time, the very early classifications, because we had only histology, were classified into groups determined by cytology and pattern of growth, and we know today that this method is imprecise. For many years now, the approach has been an integrated approach, and this has been the approach to the WHO classification, which has been in existence from 2000, and it relies on integrating morphology, immunophenotype, cell of origin, genetics, and clinical features in order to define disease entities. It includes both lymphomas and leukemias, and it consists of a large number of distinct diseases, each with distinctive epidemiology and etiology. So this is the 5th edition of the WHO classification, which started out in 2022 to 2023, but we hope to have a blue book in the next few months. And this is the list of mature B-cell neoplasms in the 5th edition of the WHO. And you can see this is a long list of entities. And this is a slightly shorter list of mature T-cell and NK cell neoplasms in this classification. So lymphomas, just like any other tumor type, you start out with genetic changes, in other words, the DNA, which is transcribed, so that is the mRNA, and then translated into protein expression, which is the phenotype. And it is this that results in the morphology or the histology that we see under the microscope. So when we see this morphology and histology, we then build up by assessing the phenotype. And this we do by immunophenotyping. Immunophenotyping, as we know, this is a sort of rather basic information, can be either by immunohistochemistry or by flow cytometry. I say and or because these are complementary techniques and not necessarily mutually exclusive in diagnostic practice. So immunohistochemistry has the advantage of the immunoarchitecture. So it gives us an architectural context of the positive cells in relation to the tissue and background populations. And also it highlights which populations are negative for the marker as well. On flow cytometry gives you the added advantage of assessing dual expression and also assessing the intensity of expression, for instance, whether it's bright or dim. And then we add to this by assessing in some cases, not necessarily all cases is this essential, but the genotypic changes and the transcribed mRNA. So we use the DNA and mRNA in assessing molecular genetics and cytogenetics. So the approach to diagnosis has to be that, I mean, if we, as pathologists, if we have to go through this long list each time we get a case in front of us, this would be very tedious. So in our heads, we should have some way of shortlisting possible diagnoses based on histology. So we'll start with histology. And when we evaluate a case, before even we start looking at pathology, we should get as much clinical information as we possibly can. And sometimes, as you know, I mean, this is the problem for pathologists worldwide. I think that clinicians are very, not always very forthcoming when it comes to giving clinical information. And sometimes, depending on what you see under the microscope, you may need to extract more information. But when we assess histology or morphology, we look at now today my emphasis will be mainly nodal. So if you take a lymph node, you have to assess to see, is the architecture preserved or is it effaced? And if it is effaced, is there partial or complete effacement? And we have to also assess to see which compartment is involved and by what cellular infiltrate. So before we look to see whether any tissue is effaced or not, it's quite useful to know what the normal looks like. And this is my diagrammatic or shall we say my attempt at a diagram of a normal reactive lymph node. And I mean, this will be too basic for me to go into this in detail. I know this talk will be available to you after the meeting as well, but this is to highlight the different parts of the lymph node. But this is what you will see under the microscope. You know, it's not all nice and neatly labeled, and it's not always necessarily that it will go through the hilum of the lymph node. So you can see this lymph node, you can see the capsular patency of the capsule, and you can see where the follicles lie. They're mainly subcapsular. Of course, you'll see some follicles cut through depending on at what plane the section has been made. So now we go on to cytology and architecture. So the effacement of normal lymph node architecture, is it effaced or not? And as I said, partial or complete. And then we have to also assess the pattern of growth, because the pattern of growth will tell you quite a lot about what the possible diagnosis will be. But obviously, it doesn't tell you all, just on pattern of growth and cytology, because otherwise the older classifications would have been still applicable. So is it nodular or follicular? Is it a mantle zone pattern? Mantle zone pattern is when you have a naked follicle center, and the infiltrate starts immediately outside the follicle center. So in other words, that's why it's a naked follicle center. And the marginal zone pattern of infiltration is what you're seeing in this image here, where you see a reactive follicle center, a well-demarcated mantle zone, and the infiltrate is outside to that, forming a cuff around the reactive follicle. Then interfollicular paracortical, is it diffuse, or are the sinuses affected? And then you move to the cytological features. Now, the cytological features, is it predominantly small cells, or does the infiltrate have a component of large cells, either present as monotonous infiltrate or sheets of large cells, or are they scattered, well-defined large cells in a background, which is either small lymphocytic or lymphohistiocytic? Or is it polymorphous with scattered neoplastic cells admixed in a background inflammatory process? So in other words, with an inflammatory background. So today's cases will be predominantly small lymphoid cells. So there are two images here. The one on the left has essentially a fairly uniform population of small to medium-sized lymphoid cells, whereas the image on the right has distinct large cells, which actually these are LP cells. Okay, so this is just to tell you what it is, in a background of small lymphocytes. So that wouldn't come under the category that we would assess, saying predominantly small lymphocytes or lymphoid cells. We would put it in this category when we are assessing it, and when we are shortlisting, it will come under this category of scattered large cells in a lymphocytic background. So we won't be touching on the cases like the image on the right, but we'll be focusing on cases which are more like the image on the left, okay, which are predominantly small lymphoid cells. So I don't know how many of you are training pathologists, but if you are sitting an exam, for instance, it's quite useful to be able to quickly construct a table such as this with the immunohistochemical markers, and which markers are positive and negative, which help you to work out what could arrive at the diagnosis based on the immunophenotype. So the differential diagnoses would be chronic lymphocytic leukemia / small lymphocytic lymphoma, mantle cell lymphoma, follicular lymphoma, and if it's in the case of a node, it will be nodal. If it's a primary extranodal, it will be extranodal, marginal zone lymphoma. So we'll come across these differentials and the utility of this table a little later on as well. But now we'll embark on the cases. So this is the first case, a 67-year-old male, right inguinal lymph node excision biopsy. So at this PAR, which is a low PAR, you can see that there is effacement of architecture, you can see in this slide, by a diffuse infiltrate of fairly uniform small lymphoid cells. And if you look at it closely, there are interspersed scattered histiocytes, and these histiocytes don't contain nuclear debris, so they are not tingible body macrophages. And if you look at it even closer, you see that these are fairly uniform to look at, and the nuclei often have this indented or fish mouth appearance. The nucleoli you can see very tiny, so they're essentially inconspicuous. This is another area of this section, and again, you see this population of medium-sized cells with the scattered histiocytes. But there are these areas where there's a well-demarcated sort of spherical areas which contain some large cells, and these are centroblasts, and mixed with some cells which are more irregular, sort of than irregular, the cleaved, I would say. But again, it's not that they look like a different population to the main population that you're seeing here, but size-wise, not very different. So essentially, what you saw there were a naked follicle center, and we'll come to that a little later on. Sometimes it's not that easy to spot. So the morphology of this is a mostly diffuse monotonous infiltrate of small to medium-sized cells with irregular or indented nuclei. There are scattered histiocytes without debris, and there are few residual naked follicle centers amidst the infiltrate. Now, one thing I do want to emphasize, and this is applicable actually in the worldwide setting as well. I'm originally from Sri Lanka, and I did my pathology training, my early pathology training in Sri Lanka. And even in the UK, it is a similar sort of situation where you have lymph nodes, which when they come as whole nodes, and if they're not sliced fresh, you find the center of the lymph node is suboptimally fixed. And if you focus on those central areas, the morphology can be very misleading. The nuclei tend to round up a lot more, and you tend to see nucleoli which look prominent when they actually are not prominent in well-fixed areas. So the morphology can be very misleading. So when you're looking at a lymph node, look at an area where the lymph node is better fixed. So what is the differential diagnosis so far? So the possibilities, so I give you all these possibilities because immunophenotypically, you should really include all possible markers to exclude these. And the reason is because although, if you have excellent morphology and you might be able to have some clue as to what the diagnosis is, but it is always important to exclude other differentials for small B-cell lymphomas. So mantle cell lymphoma should typically consist of a uniform population of small to medium-sized cells with indented or fish mouth type nuclei. They are not admixed with centroblasts, so they are a uniform population of cells, but they tend to have these admixed histiocytes without nuclear debris. So morphologically, this would be really compatible, but it would need immunoconfirmation. So you should never make the diagnosis of mantle cell lymphoma without immunohistochemical confirmation. The other possibility is a follicular lymphoma, because follicular lymphoma is a mixture of centrocytes and centroblasts, and centrocytes can also have this sort of irregular indented nuclei. Sometimes it is more cleaved, but otherwise, it can resemble the cells of mantle cell lymphoma, but they're mixed with centroblasts. And this sometimes follicular lymphoma can be diffuse. You do get the infrequent cases that can be purely diffuse, but otherwise they tend to be they are follicular, but they can be focally follicular. So nodal marginal zone lymphoma is another possibility. I mean, if the lymph node looks like the image I have given you here, it would be very easy to make the diagnosis because, as you can see, there's a very nice pale cuff of infiltrate which is surrounding this reactive follicle with a well-defined mantle zone.
All right.
But unfortunately, there are many nodal marginal zone lymphomas that don't actually look like this because it has overrun the lymph node, or the fixation is not very good and you don't necessarily appreciate all of this. So it is very important when you're including this also to keep this at the back of your mind. Then small chronic lymphocytic leukemia and small lymphocytic lymphoma. The cells in this current case have very irregular nuclear contours. So they are indented with fish mouth. Now that appearance is very unusual to see in a CLL/SLL. And I will see a case to come, but they also have an admixture of what you call prolymphocytes and paraimmunoblasts. And, this is not seen in this case. But certainly in some cases, it is not possible, especially in cases where the fixation is not very good. So this would also need to be excluded, and we would include the immunomarkers that are required for this. So we start with the immunohistochemistry. So we use CD20, which is a robust, very robust immunohistochemical marker as a pan-B marker. But just to warn you that there are rare cases of T-cell lymphoma that aberrantly express CD20. So using this as a single marker sometimes can be a problem. And so you should, if possible at all, you should also always use a second pan-B marker, whether it be CD79A or PAX5. And you can see on this immunohistochemical stain, you can also appreciate the nuclear contours here. You can see that, this irregular nuclear fish mouth appearance that I was talking about earlier. So it's CD3 negative, the infiltrate. CD3 highlights small T cells. The reason I have put the CD5 and CD43 together with the CD3 here is because CD5 and CD43 are normally expressed by T cells. CD43 is expressed by T cells and histiocytes. So when you assess a CD5 of 43, always assess it next to a CD3 so that you can do a mathematical subtraction. And you can see here that the B cells are expressing CD5 and CD43. So that CD5 and CD43 expression is aberrant. CD23 is not, there are some scattered CD23 positive cells, but otherwise the infiltrate is negative for CD23. And what you are seeing is the positivity in the FDC meshworks of these residual follicular structures. So this IgD, I don't expect you to use, but I just thought I'll show you this because it is IgD positive. So germinal center markers BCL6 and CD10 highlight these germinal centers, which you saw earlier, but they are BCL2 negative, unlike the infiltrate, which is BCL2 positive. So these are highlighting reactive germinal centers, these naked germinal centers that we saw histologically. So this is cyclin D1, and cyclin D1 is positive in the lesional cells, and you can see it coming up in this mantle zone pattern abutting this naked follicle center, which is negative for the marker. And there's another marker which is specific for mantle cell lymphoma, which is SOX11, which is a more recent marker, and this is also positive. P53 is wild type. And LEF1 is normally expressed by T cells, hence these positive cells, but these cells themselves are negative. LEF1 is also a recent marker, and its usefulness is really because in the context, it's fairly specific in the case of low-grade B-cell lymphomas for CLL/SLL. So this is negative. The Ki67 is highlighting those residual reactive germinal centers, but also you see a proliferation index in the lesional cells of approximately 15%. So this is mantle cell lymphoma with a Ki67 proliferation index of approximately 15% and a P53 wild type pattern of expression. So mantle cell lymphoma is a mature B-cell neoplasm derived from the mantle zone. It's composed of small to medium-sized monomorphic cells, and it expresses CD5, cyclin D1, and SOX11, and it's characterized by CCND family rearrangements, most commonly CCND1. So the juxtaposition of CCND1 to the immunoglobulin heavy chain locus results in the 1114 translocation, which is the genetic hallmark, and it's a primary event. It results in overexpression of cyclin D1. Now, mantle cell lymphoma is uncommon, and it's actually of the small B-cell lymphomas, it accounts for only 10%. There's a male predominance, and it involves lymph nodes, and it can also be disseminated involving the GI tract, where it's referred to as lymphomatoid polyposis. There's also a form of mantle cell lymphoma that, of course, it can involve the bone marrow, the lymph node, the ones which involve the lymph node, but there are also others which are leukemic and involve the bone marrow and spleen, and we'll come to that in a minute. So this is moderately aggressive, despite the fact that it looks histologically low grade, and it's incurable. So the median survival is 3 to 5 years. And unlike other small B-cell lymphomas, there's no transformation to a large B-cell lymphoma, but when it relapses, it may relapse with a more aggressive disease, which may be the blastoid or the pleomorphic variants. So morphologically, the typical or the classic mantle cell lymphoma, it can be nodular, it can have a mantle zone pattern, or it can be a diffuse infiltrate. It's monotonous, this infiltrate of small to medium-sized cells with irregular/indented nuclei. And as we saw, there are scattered histiocytes without debris, so they are not tingible body macrophages. The morphological variants are, so important thing to recognize is the aggressive variants are important because they have a prognostic significance. So the blastoid variant resembles lymphoblasts and have a high mitotic index, so don't misdiagnose this as a lymphoblastic, B lymphoblastic lymphoma leukemia. And the pleomorphic variant essentially has large pleomorphic cells with prominent nucleoli, and if you don't think about it, it may be misdiagnosed as a diffuse large B-cell lymphoma. The other variants are not so useful from a prognostic perspective, but the small cells can be sort of look like mature small cells and can resemble CLL/SLL. And there can be a marginal zone-like pattern with prominent foci where the cells contain more abundant cytoplasm, so imparting a sort of a monocytoid appearance. And this can mimic marginal zone lymphoma, and if they're clustered, you may also confuse it with the proliferation centers of CLL/SLL. So the message is essentially you have to use immunohistochemistry to confirm these diagnoses. There are rare cases of mantle cell lymphoma that are cyclin D1 negative. And in these cases, SOX11 is a very, very useful because we don't necessarily have cyclin D2 or or cyclin D3 positive in these cases, readily available for us to assess. Then there's a leukemic non-nodal mantle cell lymphoma. Now, this affects the blood, bone marrow, and spleen without significant lymphadenopathy. And these cells are more like CLL type cells, and these are SOX11 negative and have somatic immunoglobulin hypermutation, in contrast with the nodal mantle cell lymphomas that tend to be naive, so or unmutated. So the CD5 expression may be less common in these cases, and they have a better prognosis than the typical mantle cell lymphoma. So the prognostic factors for mantle cell lymphoma is nodal versus the non-nodal, which I've just spoken about, but also the Ki67 proliferation. So more than 30% is associated with the worst outcome. So this information you should provide to your clinician. And the presence of a TP53 mutation also adversely affects outcome. So the diagnosis, again, is mantle cell lymphoma, and you should give the Ki67 proliferation index and the P53 status. So from this, I move on to the next case, which is a 65-year-old male with an axillary lymph node excision biopsy. So this also has effaced architecture, and even at this PA, you can see some pale nodular areas imparting some nodularity to this lesion. And going closer, I mean, obviously you're seeing some vessels, but what you are seeing is a population of small mature lymphoid cells, but interspersed are scattered larger cells with central nucleoli. And if you look at the paler areas, there is an increase in both the medium-sized and the larger nucleolated cells. So these pale nodule areas, in addition to the small lymphocytes that you are seeing, which I have highlighted here in yellow, you're also seeing medium-sized lymphocytes with a central nucleolus. So this is a prolymphocyte, and also large cells scattered, which have prominent central nucleoli, and these are paraimmunoblasts. So these paler nodule areas are proliferation centers. So morphologically, what we have seen so far is as effaced nodal architecture, infiltrate is vaguely nodular due to these pale nodular areas or proliferation centers. These are not follicles, but if they're pronounced, they can give an impression of pseudofollicular appearance. And the proliferation centers are unique to, I think you know this, chronic lymphocytic leukemia or small lymphocytic lymphoma, which is the non-leukemic counterpart. So again, CD20 is positive. Now, unlike in the flow cytometry where you see a dim CD20, in immunohistochemistry, this is not appreciated. And using another B-cell marker, this is CD79A positive. So again, when we assess CD5, always assess the CD3. In contrast with your mantle cell lymphoma, there are a lot more T cells here, but still, you can see, if you go on, you can see that there is almost two-toning on the CD5. You can see that there's CD5 expression by the B cells as well. CD23 is positive, but you will also notice that CD23 is not uniformly positive. So they tend to be stronger in the prolymphocytes and paraimmunoblasts. And CD43 is strongly and uniformly positive. And unlike in the mantle cell lymphoma, this infiltrate is also positive for LEF1. So cyclin D1 is typically negative, but if you look carefully, you'll see that in the proliferation centers, there's weak positivity in a subset of the proliferation center cells. So this is, you can see it in some cases of CLL, SLL. So this is something that you have to keep in mind and not think that this is mantle cell lymphoma. So MUM1 is positive and stronger in the proliferation centers. And again, you should give a comment on the P53 status by immunohistochemistry. So the positive markers in this are CD20, it's positive for pan B cell markers, it's positive for CD5, CD23, LEF1, CD43, MUM1 in the proliferation centers. Cyclin D1 is negative in most cells, but there's very weak positive in a proportion of the proliferation center cells. So further negative markers, which you have not seen, are CD10, BCL6, which was weak, which is essentially negative, and SOX11 and CD3 you saw. P53 showed a wild type pattern, and there were no underlying FTC meshworks on CD23, which you saw, and also on the CD21 stain. So this diagnosis is quite straightforward. This is CLL/SLL. This is just another case to show you that sometimes this pseudofollicular appearance can be quite striking. And actually on immunohistochemistry, if you didn't see the H&E, you'd wonder whether you're dealing with something like a follicular lymphoma. You know, it gives you the impression that there is nodularity. And CD23, it's the proliferation centers that are strongly positive. You can see the MUM1 in the proliferation centers, which match the Ki67. So CLL-SLL is essentially a neoplasm composed of monomorphic, a small mature. So this is not taking into account the proliferation centers. This is what you see in the blood, really. Mature B cells that co-express CD5 and CD23. It must be a molecular B cell count of at least 5 × 10⁹ per liter with characteristic morphology and phenotype of CLL in the peripheral blood for us to call it CLL. So those with clonal CLL-like count of less than 5 and without lymphadenopathy or organomegaly or other extramedullary disease is referred to as MBL or monoclonal B-cell lymphocytosis. So those with a clonal count of less than 5 but with organomegaly, extramedullary organomegaly, essentially nodal, splenic or other extramedullary involvement is referred to as small lymphocytic lymphoma. So in general, when the diagnosis of CLL is made, it is on the blood. Okay, so sorry, so just a little background. It's the most common leukemia in Western countries, and it would be interesting to know the prevalence and incidence in the sub-Saharan African countries. So it's rare in Asian countries with a low incidence maintained in the immigrant population. There's dramatic increase in the over 70s, and the median diagnosis around that age, and there's a slight male predominance. Most cases, the diagnosis is actually incidental. So the diagnosis is usually made on peripheral blood. So it's characterized also by flow cytometry, and they do molecular genetics also on the blood. And what is a really important thing to assess is the IGH V region mutational status, which also gives a prognostic information, cytogenetic abnormalities, and information on recurrent mutations, which will come to, for instance, TP53. So a bone marrow is performed before commencing treatment, and also if there are any atypical features like an atypical phenotype by flow cytometry, and also once therapy has started to assess response to therapy. So 50% of these are unmutated, whereas the other half are mutated. And the IG mutated cases have a better outcome, as you can see from the median survival of 293 months, as opposed to the unmutated cases, which have a poorer outcome. So on flow cytometry, you are able to assess quite a lot. For instance, you get the phenotype CD5, CD19 is B cell marker, pan-B marker, CD23 and CD43. There's weak CD20 and weak surface IG, and CD20 and CD79B weak, and negative for CD10, negative for FMC7. So so the CLL is scored in this way, depending on marker positivity. And the immunohistochemistry we've already discussed. And also the most common cytogenetic abnormalities are deletion of 13q, trisomy 12, deletion 11q, and deletion 7p. These latter two are associated with a poorer outcome. So next generation sequencing has identified recurrent mutations such as the Notch1, SF3B1, TP53, ATM, and BERK3. Testing for these mutations we know are not widely available, but some of these mutations are associated with inferior response or resistant to certain therapies. For instance, resistant to rituximab we seen in Notch1 mutated CLL. So clinical progression is often associated with increase in proliferative activity. And in the lymph nodes, you see this as the proliferation centers enlarge and coalesce. And these histologically aggressive CLLs have an outcome, not so unsurprisingly, intermediate between the typical CLL and the Richter transformation to diffuse large B-cell lymphoma. So this was an example of a patient, a 58-year-old male, with a CLL diagnosed on co-biopsy, and now there was an enlarged neck node. And these can be quite PET-avid, just to say, these ones which are accelerated. So there is the suspicion that you get is it transformed? And the clinical question obviously was it transformed? So this, although you're seeing quite a number of these nucleolated cells, you can see that this cell composition is a mixture. There are also small lymphocytes, and there are also these intermediate-sized prolymphocytes and paraimmunoblast. So this still has the cell composition of a proliferation center, but they are quite pale because of the increase in cytoplasm in these cases. And this is what you see when you look at it on higher power. So over time, CLL can progress, and in 2 to 8% of cases, they transform and they can develop into a diffuse large B-cell lymphoma, rarely a classic Hodgkin lymphoma. So in a large B-cell lymphoma, they're essentially uniform population of sheet-like uniform population, just like any other diffuse large B-cell lymphoma. Most of these DLBCLs are clonally related to the previous CLL. And if this is the case, the median survival is less than a year, so the prognosis is poor, as opposed to a clonally unrelated DLBCL, which will behave just like a de novo DLBCL, so with a better outcome. So the diagnosis in case 2 is CLL-SLL, and the reason why these cases are biopsied are often incidental finding of a lymphadenopathy when they are assessing the patient for something else, and somehow the clinician has not even bothered sometimes to do a full blood count to see whether there is a, because if there is a raised full blood count, there's lymphocytosis, and the lymphocytosis is due to the CLL, then there's actually no need to do the lymph node biopsy. So the third case is a 71-year-old right inguinal lymph node excision biopsy. So this is looking slightly different now. There are very clear effacement of architecture, what looks like effacement of architecture with by an infiltrate with a follicular growth pattern, and there's a high density of follicular structures. And if you look carefully, this infiltrate is also extending with these follicles, and I'll show you another slide in a minute, into the perinodal fat. So you're seeing these follicles which are extending into perinodal fat, and this is not something that you see in reactive lymph nodes, so something to keep in mind. There is also quite a well-formed mantle zone in these cases. So if you look at another section of this, some of these follicles, I mean, they're not uniform in appearance, they're not small, they're varying in size to some extent, but it's really densely packed. So looking at it a little closer, you can see the follicles. You can see here there's there's a mantle zone here, but you can see the follicles consist largely of centrocytes. They are mainly small cells, and they don't really have tingible body macrophages. So this should alert you into what's going on here. This is not normal follicle. So the question is this follicular lymphoma? Is this reactive follicular hyperplasia? Or is this another histologically low-grade B-cell lymphoma? So let's just park the third possibility for a minute and just focus on these two possibilities, follicular lymphoma versus reactive follicular hyperplasia. So if you go back to this case, the sinuses are not patent. It's densely packed with numerous follicles, and this infiltrate is seen to go out into the beyond the capsule. But the mantle zone is well formed. So these three features, which is sinuses not patent, obliteration of sinuses, densely packed numerous follicles infiltrating beyond the capsule, would favor follicular lymphoma because these features do not favor a reactive process. So this was the reactive follicular hyperplasia that I showed you at the start of the talk, and this is on the left is case 3. So you can see the distribution of the follicles in this reactive follicular hyperplasia is very different to this dense infiltrate where the whole lymph node seems to be involved by this follicular process. So if you look at these follicles, as I said, there seems to be there are no tingible body macrophages to be seen, and they seem to be mostly composed of centrocytes. Now compare this to a reactive follicle. So this is a hyperplastic follicle, and you're seeing very nice zonation here, the dark zone with the predominance with centroblasts, where the tingible body macrophages live, and then this is the light zone on this side. Yes, both, of course, have this well-formed mantle zone. So this is quite different from a reactive follicle. So looking at it more closely, you can see, yes, this has a predominance of centrocytes with definitely less than 15 centroblasts in a high power field. So if you compare this with a case of follicular lymphoma, it's another case. So you are seeing a mixture of centrocytes and centroblasts like you're seeing here. So you can see that depending on the fixation, not all follicular lymphomas look alike, but the cell composition is similar. And you can see on the case on the right, you can see also that there are centroblasts. Centroblasts have these peripherally located nuclei, a bit like what a potato looks like with the eyes of the potato. And here again, there's a very nice centroblast. These may not be that well preserved, but again, you can see they're peripherally located nucleoli, sorry. So then we also have to consider, so now we are moving away from a reactive follicular hyperplasia to a lymphoma. But what about another histologically low-grade B-cell lymphoma? Let's just keep comparing. So on the left-hand side is our case, and on the right-hand side is a mantle cell lymphoma. And not the case that you saw, but this is another mantle cell lymphoma. And you can see a uniform population of cells. This is an FDC here. This is within a it's a nodular growth pattern where there is an underlying FDC meshwork, and there are some histiocytes. And here you're seeing these are much more cleaved, elongated and cleaved, the centrocytes, and you're seeing these scattered centroblasts. So we saw this mantle zone pattern here, which also is something that you can see in mantle cell lymphoma, but you can see that the proliferation seems to be really outside of this naked germinal center. What about nodal marginal zone? So nodal marginal zone lymphoma, this is that image you saw earlier, slightly smaller. I mean, the problem, as I say, is not all lymphomas read the textbook, you see. So it doesn't always have a textbook image like the one you're seeing here, where if you see the process on the left is mainly a follicular process. The process on the right, you can see, has a marginal zone distribution. And if you look at the follicles, they will be reactive looking follicle centers. But unfortunately, sometimes when the node is completely overrun and fixation is not always great, it can be quite difficult to work out whether, and we'll come to this in a minute, sometimes a nodal marginal zone lymphoma can colonize the follicles and also spread outside to the rest of the nodes. So then can be quite difficult to work out, is this an infiltrate that is actually coming out of the follicle, or is it secondary colonizing? So it's not always that straightforward, and therefore immunohistochemical confirmation is essential. CLL/SLL is a little easier if the fixation is decent. So you see this on the left, you can see these centrocytes predominating, but also a mixture of centroblasts. And this is a proliferation center with predominance of these central nucleoli within these prolymphocytes and paraimmunoblasts. So this is quite different in appearance. But nevertheless, as I said, always include the immunohistochemical markers required. So this is the CD20, and the CD20, all it is telling you really is that in addition to highlighting the follicles, there is an infiltrate outside the follicles, which is quite dense. And this is something that you shouldn't really see in a reactive lymph node. Okay, so from this, we move on to the germinal center markers. So this is a CD10. It's positive in the follicular areas, but also you're seeing it in the interfollicular areas, although far fewer. So there's downregulation in the interfollicular area, but nevertheless, there is some positivity, which is not what you really should see in a reactive follicle, where the germinal center B cells should be actually confined to the follicle center. Similarly, BCL6 is prominent in the follicles, but downregulated the interfollicular area. Just to say, in follicular lymphoma, the CD10 and BCL6 are upregulated when there is a FDC, follicular dendritic cell milieu, and is downregulated outside of the follicles where there are no FDC meshworks. And similarly, if you look at a bone marrow involvement by follicular lymphoma, these also would have downregulated BCL6 and CD10, and except by flow, which picks it up. It's not always easy to pick it up on immunohistochemistry on a bone marrow troponin. So BCL2 is positive in the germinal centers. You can see that here very strong. Always compare it with the CD3 and CD3 because T cells are positive for BCL2. So therefore, if you have a follicle which is rich in T cells, it can confuse you. So always do this subtraction story. And of course, this is CD5 negative as well. CD21 and CD23 highlights these FDC meshworks. And the Ki67 is moderate in the follicles and lower in the interfollicular compartment. Contrast this to the reactive follicle centers in case 1, which had those naked germinal centers. But of course, if the centroblasts are, if it's a higher grade follicular lymphoma, the proliferation will be higher. So this is follicular lymphoma grade 1 to 2. The WHO of 2023, the classification does not require you to grade follicular lymphoma grade 1, 2, and 3A. So you can just refer to this as classic follicular lymphoma. But I guess it depends on what your clinician would want. So grading of follicular lymphoma, we know that 1 to 2 is considered low grade, and 1 to 2 should have between up to 15 centroblasts per high power field. And if there are more than 15 centroblasts per high power field, if there are still mixed centrocytes and centroblasts, you call it grade 3A. And grade 3B are solid sheets of centroblasts. Grade 3B in the new WHO classification is referred to as follicular large B-cell lymphoma because it is, as I'll come to it in a minute, it's different from the classic follicular lymphoma, which is grades 1, 2, and 3A. It's more akin to diffuse. Grade 3B is more akin to diffuse large B-cell lymphoma. So grading, these are examples of grade 1 where the centroblasts are less than 5, and this is grade 2. So we don't refer to as grade 1 and grade 2 anymore, it's grade 1 to 2, and this is a 3A where there are more than 15 centroblasts, but there are still centrocytes, and then of course the sheets of large cells which are within the follicle, which is follicular lymphoma grade 3B, which is now called follicular large B-cell lymphoma. So the immunoglobulin B genes show extensive and ongoing somatic hypermutations. So sorry, there's a typo here. In more than 90% of cases of low-grade follicular lymphoma, much less frequently in grade 3B, you have the characteristic rearrangement, which is the 14-18 translocation involving the IGH and BCL2 genes. So we know that BCL2 is an anti-apoptotic gene, which has to be switched off in the reactive normal germinal centers. So by this enhancement of BCL2 gene, you get an anti-apoptotic effect, and this is seen particularly in the low-grade follicular lymphomas. So in addition to 14-18 by itself is not enough because you can see that in situ follicular neoplasias, you need other genetic alterations in follicular lymphoma to develop overt follicular lymphoma. So as I said, the indolent ones are grades 1, 2, and 3A. 3B is biologically closer to diffuse large B-cell lymphoma than other follicular lymphomas. So the natural history is different from other follicular lymphomas and resembles diffuse large B-cell lymphoma. Up to a third of cases of follicular lymphoma transform to diffuse large B-cell lymphoma, and the transformation is typically associated with additional genetic abnormalities. And if a MYC rearrangement occurs, the combination of MYC and BCL2 can be very aggressive. And these are referred to previously as double hit lymphomas. And now we just refer to it as either a large B-cell lymphoma with MYC and BCL2 rearrangements in the new WHO classification. So this is another example of a follicular lymphoma, just to say that sometimes, now in the one on the left, the follicles are very well defined, and the one on the right, they are less well defined. And you might think, could this be mantle cell lymphoma? Could this be something else? So therefore you have to be very careful. Sometimes if the histology is not very well preserved, you can have diagnostic difficulty, okay? So this was the example. This is our case, and this is the follicular lymphoma that I just showed you on the right here. Actually, the cytology is better preserved in this case when you look on higher power. So diagnosis of case 3 is follicular lymphoma grade 1 to 2, or classic follicular lymphoma. So the last case I'm going to show you is a 55-year-old male, and this time we are moving away from a lymph node. This is a gastric biopsy. So this gastric biopsy, you can see that there's a dense lymphoid infiltrate. There could be some vague nodularity, but essentially it looks diffuse. And what you can see is that it has overrun some of the pre-existing acinas, the crypts. And if you look closely, there's also there's infiltration into these crypts with some eosinophilia of the crypt epithelial cytoplasm. Now, remember that reactive base lymphoid aggregates may be seen, but they are basal and they don't extend up between crypts. In this particular case, the infiltrate is too dense with effacement of architecture and infiltrate extending between glands. So this is not reactive. So this is definitely lymphoma. So the differential diagnosis would be of histologically low-grade B-cell lymphomas. So because the site is gastric, you have to consider an extranodal marginal zone lymphoma of mucosa-associated lymphoid tissue. I'm sorry, there's another typo here. So it's mucosa-associated lymphoid tissue. I'll correct this when I send you the PDF copy. Or Malt lymphoma. Then other small B-cell lymphomas can also involve the stomach, usually as part of disseminated disease. morphologically, CLL/SLL is composed of small mature lymphocytes, which may be mixed with prolymphocytes and paraimmunoblasts, but sometimes, in crushed biopsies and so on, this can be difficult to appreciate. Mantle cell lymphoma, we've discussed this. They're uniform population of medium-sized cell with indented nuclei. Rare subtypes like small cell and marginal zone-like may occur, which can cause confusion, but it has this histiocytes with no debris. The follicular lymphoma is follicular architecture. Occasionally it can be diffuse, and there's a mixture of centrocytes and centroblasts. So extranodal marginal zone lymphoma, you can see a nice marginal zone pattern, but the follicles may be overrun and colonized, and this can be quite difficult then to differentiate. So small lymphocytes, you can see small centrocyte-like cells, you can see medium-sized lymphoid cells with a monocytoid morphology, and a few scattered large cells. So malt lymphoma in epithelial tissues, the neoplastic cells typically infiltrate the epithelium to form what is called lymphoepithelial lesions, recapitulating the normal malt that you see in the small intestine in the Byers patches. So this is, you can see this eosinophilia associated with these lymphoepithelial lesions, which are actually best appreciated by a pancytokeratin. And in this particular example, not in this case that I showed you, this has these monocytoid looking cells with these almost like fried egg appearance. So if you're lucky, when you make the diagnosis, it will look like this, where you have a nice follicle center, you have a mantle zone, and you have a nice marginal zone around it. But unfortunately, you're not always that lucky. And what you invariably get is biopsies which look like this. So where the infiltrate has colonized and overrun the pre-existing acquired malt or the acquired mucosa-associated lymphoid tissue from which the tumor has arisen. So the neoplastic cells reside in marginal zones of these reactive follicles, and they extend into the interfollicular regions as well as cause follicular colonization. So you can see how this orange part can actually occupy practically the whole of the tissue. So this is essentially what you're seeing here. You're seeing this extensive, dense infiltrate, which is positive for CD20. And you can see here how it's going up, creeping up between the follicles. And as I said, the lymphoepithelial lesions are better appreciated on the A1, A3. So comparing the CD3 with the CD43, this is expressing CD43. Not all malt lymphomas will express CD43, just to say. And on the CD21, this is something that you tend to see, and this is something which has given rise to this nodularity. So when it colonizes these follicles and sometimes overruns it, there is this disruption and expansion of the underlying follicular structure. And this infiltrate is BCL2 positive, but again, this is not very, this is just to tell you that it is BCL2 positive, but it doesn't help you to differentiate it with any other type of lymphoma. CD10 and BCL6 are negative. And in this case, this is our light chains. And just to tell you, when you interpret light chains, in plasma cells, it is quite easy because you have intracytoplasmic immunoglobulin. But in the small B cells, you have to look for synthesis of the immunoglobulin in the cell. Because immunoglobulins have a low molecular weight, there tends to be a lot of diffusion outside the cell. So if you see something which looks like membrane type positivity, like you're seeing down here, it is probably interstitial staining, which is sticking onto the membrane. So it's non-specific staining. So if you're looking for specific staining, you should look at the perinuclear space, which is where the rough endoplasmic reticulum is and where the synthesis occurs. And this is how it should look. So if you look at these, there is this, I don't know how well you can see it, but this is almost outlining the nucleus, and that is essentially how you should see it. So it's positive for kappa and negative for lambda, so it's kappa light chain restricted. So further immunohistochemistry, which I didn't show you, was that it was negative for cyclin D1, CD5, and CD23. H. pylori was negative, but I've just shown you an example of H. pylori positive case, which is, you can see here, this we use immunohistochemistry. And CD138 highlighted only a few plasma cells. Sometimes, in some cases, this may be prominent. So the immunoprofile positive for PAN-B markers 20 and 79A, CD43, BCL2, and it was kappa restricted. Negative markers were the germinal center markers, cyclin D1, CD5, and CD23. And you saw these expanded and disrupted FTC meshworks, which were seen on the CD21 stain and also on the CD23. So this is this the table that I showed you. And so if you look at this malt lymphoma and you look at the immunostains, so CD5 in malt lymphoma is typically negative, but rarely it can be positive. Generally, when it's positive for CD5, it's negative for CD23. So it's negative for CD23. And cyclin D1 and SOX11 will be negative, and it will be negative for the germinal center markers. So CD43 may be positive, like in our case here. And really the use is to differentiate reactive from lymphoid hyperplasia. So when it's very early malt lymphoma, and it's where you have spillage of cells from the base and creeping up, and you see the CD43 positivity in the B cells, that is very helpful. So left one, as we know, will be negative in this case. And also something which is important to recognize that sometimes this is can be very confusing in the lymph node setting. It can also happen in nodal marginal zone lymphoma. Some germinal center markers may be upregulated in the follicles when malt lymphoma shows follicular colonization, but it is not present in the interfollicular areas. So this diagnosis is extranodal marginal zone lymphoma of mucosa-associated lymphoid tissue or malt lymphoma. It is a primary extranodal indolent B-cell lymphoma. Cytoarchitectural features resemble the Byers patch lymphoid tissue, which is a prototypical normal mucosa-associated lymphoid tissue or malt, typically arising in the marginal zone of an acquired malt, often associated with an underlying chronic inflammatory disorder. So as I said earlier, reactive lymphoid hyperplasia needs to be differentiated from early malt lymphoma. So they tend to be basal aggregates, but you can see if there's some spillage in outside, for CD43 can be quite useful. So remember, mantle zone B cells are IgD positive. So if you see an infiltrate which is expressing IgM and negative IgD spilling out from the follicle into the outside of the mantle zone, then that would be useful as well. Light chain restriction is useful, but it is better seen if the plasma cells are neoplastic when you see this abundant intracytoplasmic expression of the light chain. And also, of course, other B-cell lymphomas, as we've discussed. We've gone through this, so I won't go through it again. And the etiology in many malt lymphomas, there's a history of chronic inflammatory process. It's interesting that actually malt lymphoma is very rare in sites of normal malt. So for instance, the ileum, for instance, it's very rare to get a malt lymphoma. So these are acquired malt, like for instance, in the stomach, secondary to Helicobacter gastritis, or salivary malt lymphoma, secondary to Sjögren's syndrome, thyroid malt lymphomas due to Hashimoto's thyroiditis. So the stomach is the most common site, but other sites, conjunctiva, ocular adnexia, skin, lungs, salivary, breast, thyroid can all have malt lymphoma, even soft tissue. The course is indolent and recurrences tend to involve other extranodal sites. And you can have a lung malt, which can also be disseminated into the stomach and so on. So protracted remissions may be induced by antibiotic therapy in the case of Helicobacter positive malt lymphoma, and other sites also, for instance, conjunctival malt, etc. They're not Helicobacter, by the way. And then you have transformation to diffuse large B-cell lymphoma can occur in a small proportion of cases. The diagnosis in this case is extranodal marginal zone lymphoma or mucosa-associated lymphoid tissue or malt lymphoma. So I leave you with this table, which is useful for trainees. And I thank you for your attention, and I'm willing to take any questions.